everybody. It's Robert Libby, registered massage therapist, instructor of Ligamentous Articular Strain Technique, and author of the best-selling book Ligament Pain Referral Patterns. I'm coming to you today because I've got an interview with Walt Fritz that I think is going to add some value to you as a clinician, to your practice. I think it's going to provide some education to you that's going to benefit your patients. Walt is a physiotherapist. If you don't know who Walt Fritz is, Walt is an amazing physiotherapist out of Rochester, New York. He's been practicing since 1985. He's been teaching since 1995. So he is very well known, very well respected globally in the manual therapy community. And in all honesty, he's just like a super nice guy, just like an honest gentleman, just so knowledgeable and so giving with his information and his knowledge and his experience. He's just a fantastic guy. So earlier this week on social media, Walt had posted a image of an x-ray of his hand post-surgery. So he'd gone through sort of a degenerative process of the trapezium in his hand, and then had to have had surgery for it in order to stabilize it and make it more functional. So he posted the image of it. I thought it was really interesting. And then I contacted him and said, hey, would you mind doing an interview? Because I think that there's some great value in what you know as a clinician in your perspective, migrating from more of a biomechanical perspective to more of a neurocentric biopsychosocial application into manual therapy perspective. And also as a patient. So I think it's a really good video to provide you with some value to, again, like I said, to you and your practice, and also I hope it changes how you interact with your patients also. The topic was supposed to be on the hand, but very quickly, we kind of got off the rails and started going into subject matter that really sort of benefits you generally as a clinician. Walt and I seem to have been along sort of the same developmental trajectory through our practicing careers, where we started very biomechanical. Now we're less biomechanical, still acknowledging the biomechanics, which you can never throw out, but being more of a neurocentric sort of perspective clinician. Really acknowledging more of a biopsychosocial, perspective with how we treat and how we speak and the narratives and the terminology that we use. You'll get a sense of that from the video, but I just thought that this would add some value to you guys. So sit back, grab some popcorn, and enjoy the video, and we'll talk to you soon. See you guys out there. Okay, I don't want to take up too much of your time, but thanks so much for doing this.
Sure.
Totally greatly appreciate this. It's just, when I see really interesting things come across social media, I just kind of like to jump at the opportunity, just because I know that there's been times, probably in your practice as there has been in mine, where, somebody walks in off the street that you've never heard of before, you've never seen before. And, new therapists that I've had in my office, they just kind of vomit in their head quite a bit.
Yeah.
And then, they come running to my door. It's like, what the hell do I do with this thing? It's like, well, treat it as you would normally, don't hurt the patient. Things like that. So
I find it interesting too that, and there certainly are disorders and dysfunctions that we need to know the details of. But the feeling like, I see it in massage therapy, where I'm not trained, I'm not certified in this. Where do I get the training? It's like, well, is it that much different? Now, and I get beat up on all the time, okay, I never took a cancer certification. It's like, they're humans with cancer, right?
Yeah.
Now, certainly you don't want to be doing stuff to my hand that the doctor said you shouldn't, but I mean, we can't train for everything. We can't get certified or take a seat. Where did that come from? Who put that in clinicians' brains that every single thing needs to have been taught to them? I don't know.
That's been there since I was in school, and that was 29 years ago.
Mm-hmm.
And in school, we were like, oh my God, I need to become a Rolfer. That was the big thing. Like 29 years ago, it was like, you have to do, Rolfing is like the best thing ever. We have to do that.
Yeah.
And then I have to learn about cranial, and then I have to learn about how to, do surgery on visceral tissue.
Exactly.
So I have to take all that stuff.
Yeah.
And I think the really important thing that I try and get across to students that I teach in my weekend courses or even when I taught at college was just common sense.
Yeah.
Just common sense. Like I had, I'm teaching a course on elbow, forearm, and carpals this weekend. So that's why I wanted to take this opportunity.
Okay.
And I've got a case from 20 years ago where a gentleman was all-terrain vehicling out on a boys' weekend. He went over a fallen tree, but there was a ravine, about a 40 to 50-foot ravine on the other side that he didn't know was there. So he took a vertical dive down, held onto the handlebars, and as the handlebars impacted the ground, his humerus kept going.
Ah.
So there was surgery, plates, pins, nuts, bolts, screws, meshes, all that kind of stuff. And because there was structural change that occurred to the olecranon fossa, he was no longer going to get full extension of his elbow. It just structurally wasn't capable of happening. And we had that conversation. So then that removed that goal of returning that function back from our treatment plan. But he was also seeing another medical professional who didn't have that perspective. And she was going to get 100% range of motion. And he came in one day and his arm was the same width span as my thigh. And I thought, dude, what did you do? He's like, she got 100% range today. I was like, no, you can't do that. Yeah. So I called the surgeon. The surgeon is pissed on the phone. Sent him in. Luckily, I got all of his x-rays. So she bent the plate, anterior, posterior, and lateral, and pulled all the pins out.
Crazy.
So now he's gone through, a first surgery. He's got to go through a second surgery to repair the first surgery, and then his body went through rejection. Like, get this shit out of me. We don't want it. So he had to have it all pulled out. And now he's got less range of motion than he would have had if it just would have never happened. So common sense, right?
Common sense. Yeah.
So I know some therapists that have looked at your x-ray that you posted on social media and said, could we do grade 4 joint mobilizations to that? I'm like, well, let's run through some common sense on that. Would you need to? Because
on my hand, you mean?
Yeah. So like on anything that presents to you, you have a certain span of things that you're going to do, applications you're going to apply to that patient's body. And you need to decide, are they relevant? Yes. Is it necessary in order to do that? Yes. Does he need that? Maybe he's got full function, full sensory, full motor control. Maybe he's got no deficiencies or dysfunction whatsoever.
Yeah. And the nuances of this procedure is I'll never get thumb abduction like I once had. It's built in the way the surgery is done, and I apologize, I can't remember whether they use wire or nylon to do the 2 loops through the drywall anchor. It looks like a drywall anchor.
It does.
Space, right? And then they drill holes at the base of my first Medicare, sorry. And part of that procedure is closing up the palm a bit. And one of the things that I read both online as well as my surgeon told me is you'll always feel deficient wiping a window because you'll never be able to get flat or flat on a counter, right? And it's like, part of me, my old MFR brain said, well, I can fix that.
I can change that.
But should I be trying, right? Because if we lose that, if we gain flatness, what am I losing from a functionality and potentially integrity of this repair? Yep. This is my 3rd day not wearing my splint here in the clinic doing hands-on work. And, I feel vulnerable here, but I feel vulnerable here, right? But it's been just fine. I think I'm about 6+ weeks out. Okay. It's certainly, if I'm a clinician and I'm coming in to see them, if I don't know the procedure, I might need to learn more. I don't need to take a class on that, I don't think, right? You call the surgeon or you look it up, right? But still, a lot of patients come to us with a framework of, here's what the doc said. Let's do stretching, let's do exercises, etc. And it's pretty good. It looks goofy. I don't have a trapezium now. My wrist is different, right?
Yeah.
Swelling takes 6 months to go away, but it looks funky to me. It's smaller. I'll get over it, and you know what? I'll move on in life. I can do things. This is crazy. What I couldn't do before surgery, I couldn't reach up to a lamp and turn that little knob thing to turn the light on, and now I can. So that's not how I'm measuring success, but so far so good.
It's an improvement in quality of life.
Oh yeah, yeah.
Right. So
Yep.
so that's sort of a level of measurement that we do with patients also. And I like
Yeah.
how you said that you feel vulnerable here, but you also feel vulnerable here.
Yeah.
And I think that is an important distinction that a lot of therapists, new and old, don't make.
Yeah.
They don't get that.
It's cognitive processing. Okay, so what is it? Is it pain? Is it weakness? Is it fragility? Right? But our tissues don't feel that. Our central nervous system and brain are giving us that feedback. And it's like, okay, I need to prove to myself dozens and dozens of times that I'm safe and I won't hurt this thing, so that this calms down, and this can do what it can.
I bring up a slide in my PowerPoint on DIMS and SIMS. And I've basically got, I think I saw it on one of the skeptical or one of the pain science social media of the dim sums. And I basically just took that picture and I made it a better picture and I made it dim sims. So we talk about that in class also. And it's funny that you talk about, like, okay, well, I'm safe, or do I feel unsafe because now there's this, foreign object, there's a piece of me that's missing.
Yeah.
I'm a cyclist. I have a friend who's broken both of his clavicles. I was present for both of the falls. And his perspective is that he is now faster and stronger and has more endurance and stability because he's now a Terminator. He's now stronger, so he can put more force into the handlebars in order to propel himself forwards.
Yeah.
So it's gone the opposite way. It's gone a different way than what most of my patients go. They go into the fear and the unsafe sort of psychological perspective.
And I have the negative from my surgeon, who said because the trapezium is no longer there, and in essence it's created a floating joint instead of a compressive joint. He said you'll never quite have that ability to grip like you did. And okay, again, that defiant little child in me said, "Oh, damn it, I will," right? But I'll learn compensation methods for that, right? My hand is altered, but you know what? I'm going to move on and figure out a way to keep doing all the things I want to do, or I'll modify the ones that I can.
Yeah, and there's that negative terminology of the clinician imprinting, a psychological barrier into the patient. You'll never be able to do this. You won't have this. This is going to be something that's going to be potentially not fun for you for the rest of your life, and so on and so forth.
Or conversely, something so idealistic or unrealistic that you're constantly chasing that carrot. I just think that's so unhealthy, and it's it's unfortunately common in our shared professions. People get trained in the silo of a modality, which is the greatest thing ever invented. And then they go talk in it. We do good work. We all do good work. But is one modality better than another? I don't think so. It's the clinician who's applying it. And if the clinician can stay level-headed and not going to, too much selling of bad science and bad narratives, I just think we have a realistic way to help people without overselling people and keeping them on a string for months and months and months and not changing. So,
absolutely.
I see it, we all see it all the time on social media with these threads that just go off the rails where, I've got this problem, and then just people start barraging like, oh, have you tried this? Have you tried this? Have you tried this? And I want to say, have you tried actually sitting down and talking with somebody instead of just throwing modalities at people,
Yeah. Yeah, two things on that. I've had a number of patients recently because of COVID and the restrictions have been put in place on physicians and now doing more of this sort of interview with their patients. We haven't had a lot of restrictions in British Columbia. We've been allowed to practice with certain limitations and so on and so forth. But all of my patients, they've come to me and they've said, you know what, the thing is that we really like about how you practice is that you're not eager for us to jump on the table. You sit down with us, we talk about our day, we talk about our lives, about our experiences, our fears, our anxieties, things that we are now educated from you that impact our physical bodies and what we're experiencing. And we get to talk that out with you. We know that you're not a therapist, you're not a you're not a counselor, but you listen. And then based on what you gather from our history and our interview, then we determine, a mutual plan of attack for treatment.
Yeah.
And
narrative medicine, right? That's what it is.
Exactly.
Yeah.
And the other thing was I'm just going to be teaching for Aubrey out in Ireland this coming weekend. And the first time I met Aubrey was when I was teaching a course in Scotland a number of years ago, and I invited him over to come take the course. And he says, I came into your course thinking it's going to be one of those typical modality courses that you just get high sold on everything. He said, 3 minutes into it, I quickly realized that this isn't a modality course, even though you're teaching modality. It's not a modality course. It's a therapist development course. Mm-hmm. And you brought in so much more stuff that the modality aspect of it was sort of the most minimalist part. And how, it's not the be all and the end all. It's not the best thing since sliced bread, and that it's no better than any other modality that's out there. Yeah. And there's so many times where you need to recognize that, that modality or a group of modalities are completely CI'd. It's not warranted for that patient. It's not necessary for that. So, like grade 4 joint mobilizations, is it necessary for Walts? Maybe not. I don't think so. Structure's changed. He's got, he's a Terminator now. So do we want to take that away from him? So.
And honestly, if you start to push me into wanting to do grade 4s on this, I'll find someone else,
Yeah.
But then, you and I carry into that therapeutic setting a certain knowledge set from the physician, from our own experience. It's like, you know what, I don't think that's in my best interest. And I do feel that our patients, they give up too much power to us to do what we think is best under the guise of, I hope he helps me, so I'm going to give him a lot of rope here. Yeah, this feels dangerous, but he sounds like he knows what he's doing. And that's where my model is one where I know a lot about a lot of stuff, but I don't know what you're feeling and fearing and hoping for until we have that dialogue. And Absolutely. My approach is all about everything I do is based on your feedback. More so than, when I was in BC a bunch of years ago teaching at that class, I've really gone even more into the patient perspective, driving the intervention, letting go of my ego to the point where, we are truly equal partners in this. And some patients don't like seeing me because I'm too needy. I ask too much of them. They expect me to know what to do, and they'll go find somebody who acts like they know what to do. I feel real strong in this work, and whether it's working with a massage therapist, physical therapist, or speech pathologist, teaching them to share power in the relationship.
Yeah, yep. Creating balance in a therapeutic relationship is huge.
Yeah.
For whatever reason, just as an aside topic, I have a large percentage of my patient load that are patients of abuse, either physical abuse or mental abuse, psychological abuse. Most of it's female based. It's physical abuse. And I wrote an article on that got published around the world on recognizing all of the dynamics that go into a therapeutic relationship, and how you just said, placing all the power on the practitioner and taking the power away from the patient. You've got to create a balance. This is a relationship that has to benefit the patient. And I know, like I've left clinics where the owner, the main medical practitioner, was just a silverback gorilla, and that's just not how I work.
Yeah, you think of something, and I'm gonna stereotype and generalize a little bit, right? A massage therapist walks into their patient in the room already on the table, possible, right? you're already created a disparity in power in the relationship. You're standing over them. And I think that that's something that, from the most simple form, sit that patient up. Get yourself lower than them on your stool and let them feel, at least in that little bit of the relationship, that they have power, so that they can start talking to you about what they're looking for, what their goals for the session are. And, you know, it's not that I sit everybody up every single time we need to discuss something, but it's like, start out the relationship in a way where you're not the power figure. And because, you know what, Robert, no matter how much people tell us, we'll never know what's happened to them in their life. And, you know, sometimes they don't, obviously, right? But so I have to make a basic assumption that this person, like every human being, is vulnerable and potentially fragile. And even the big silverback gorilla, right? Like you said, I want to take the same respect with him or her as someone who is, quote unquote, earmarked as having some trauma issues. I want to give them that same level of respect and care in all parts of the relationship.
Absolutely, absolutely.
So,
we're on the same page, man. We're on the same page.
Yeah. All right.
Okay, so a couple of questions that have come from a few people through emails. So when did the symptoms start? What were the symptoms? How did you modify your lifestyle in any way to accommodate those symptoms?
You know, when I look back, I would guess it's the last 3 to 4 years, I noticed more pain and pain-introduced weakness in terms of, it's primarily a grip, a pincer grip, that sort of thing. But then I started to notice it in my work. So I do an MFR style of work. I don't do MFR, right? But which is a lot of weight bearing through the heel of my hand. I found myself needing to modify mildly in that. I never wore my brace during treatment, but I usually wore my brace before the surgery when I was doing work around the house. It stabilizes that first metacarpal joint. This is literally a brace designed for somebody with first or basal joint insufficiency problems. And yeah, the primary thing was probably grip, like that. I mean, how insignificant is turning a lamp on and off like that with that little dial switch, right? That I couldn't do. But it was also other affecting, you know, we have a 200-plus-year-old house that we're constantly tearing walls out, putting new windows, and I could really feel it with that. So it was a degradation of that. I probably could put it off. I could have put it off. The surgeon was like, you know, you're on the fence. He said, I might not do it yet. And I said, well, I'd like to. And primarily it was purely selfish because I had a 2-month window. I had a UK class that was canceled. So I had this window of 2 months that I seldom have when I'm not traveling to teach. So I said, you know what, let's do it. So we did it. And that's, you know, I teach this weekend and I'm ready to go. Okay.
Nice.
Did I get all your questions?
And was it the trapezium that was sort of degrading?
Yeah, it's the both parts of the joint, right? The first metacarpal within the trapezium. And you know what? I honestly didn't ask him which one is in worse shape. I really didn't. Now that the trapezium is gone, you just see if you can pop up that X-ray that I shared, I can send it to you. It's an image too if you want it, Robert. You know, you really don't see a whole lot of the joint surface itself. So I don't have an answer for that, but there's a couple different procedures they do. One is to tendon harvest somewhere from your elbow, and they take a tendon and they harvest it in here. That is a much more complicated procedure. Not only because you have a lot longer healing, but it's healing up here too. But the long-term outcomes between that one and this one are the same. So a lot more downtime with the other one. This newer procedure, where they basically, it looks like a drywall anchor. They screw into your second metacarpal, is a lot quicker recovery and the same outcomes as the more involved procedure.
So they haven't fixated one metacarpal on another. They've just stabilized the second metacarpal.
No, the second one is used for, right, the stability, so that it creates an anchor. If you pop up that X-ray, you'll see at the base of that little anchor they put in there, you can actually see a hole, and that's where they run the thread or the wire through. It's just an anchor to then wrap around and through the first metacarpal to give this more stability. Okay. So there's really no fusion of first to second or anything like that.
Okay. Okay.
And from a self-recovery standpoint, wrist mobility is really good. I lack a little bit of radial deviation because we still got healing going on in that part of the hand. And I can see it. It still has some edema in there after 6 weeks, and it'll slowly dissipate.
Any possibility of increasing or creating a bit of hypermobility in other structures because that trapezium has been removed?
You're asking me, or from my opinion, or was I told?
Let's go both.
I wasn't told anything. I didn't actually think of asking that question. I could see some hypercompensation occurring. It's not going to happen right now because things are still. I still have low levels of pain and low to moderate levels of inflammation, edema. I don't know that that's going to be a huge issue. Can you, without really jumping up and down on the carpals, can you really overcompensate much? Right?
Yeah.
Probably not. I'm hoping to get full motion out. I've got supination, pronation, flex. I'm just kind of lacking that whole, and it's a little awkward yet. It feels awkward.
And that'll change over the next 6 to 8 weeks anyways.
Absolutely, yeah.
A year from now, it'll be different.
Yeah.
I say that a lot to my patients, like, well, a year from now, it'll be different. And they're like, oh, we weren't even thinking a year ahead. I'm like, that's where I'm thinking.
Yeah. And I do understand that sometimes physicians or surgeons will use that year as that carrot out so far, by the time a year comes, either you'll be actually better or you'll have forgotten about it and accepted what you have. And I think there's a little bit of both going on there, right? And it's just kind of psychological reasoning. So
let's see, describe surgery, the intended outcomes. We've sort of covered that. How's recovery? We've talked about that. There were some questions about self-treatment. And then with our knowledge of scar tissue development, adhesion development, from Kathy Ryan and all her amazing stuff, and Jeffrey Bove, and oh my God, I forgot her name. Susan Chappelle.
Yeah.
Are you doing any D&M stuff? Are you doing any little area self-treatment?
I do a little bit. I do a little bit. In fact, it was actually really wild because I got my, the handout after the surgery, and I was pretty out of it still. And I came home and, it said to actually use Dicem on the scar. And it's like, wow, that's interesting that Dicem has made it into this surgeon's routine of telling people basically just to do some skin stretch. And we could talk for hours, and a lot of people could talk for hours and argue for hours about what's really happening with remodeling of immature versus mature scar, right? But I kind of started that in really fast in terms of doing just general, let's keep it moving, whether it was a static engaged stretch or just massaging the scar. It's all good for it, whether it's affecting the scar or the surrounding system or the nervous system or my brain saying this is safe to do, right? There's so many things that happen when we treat scars, even though I was taught MFR is releasing that scar that nobody else can release, and that's bullshit. But you know what? It's a good story. It's getting the person involved in their own self-care, having some sense of power in the whole thing, I think is probably what the deal is. I started a little bit of like, okay, so we've got some of those kitchen tongs, right? I was using those as a little bit of resistance exercise, probably at about 10 days out. And, I did a day of that and thought that I had broken something because it was just way too much, way too soon. I stopped doing that and I just started using it, first the splint allowed and then this little splint allowed. I went to PT last week, one visit. It was a joke. She didn't listen to a word I said, oh, do you use heat on your hand? I said, no, I haven't found it effective. Okay, let's put some heat on your hand before we start. And it's like, it's time management, the whole thing. Basically, I was told I was doing too much and stopped doing it. And I felt like saying, I don't want to like get too rude with your audience, but like, F you, I'm not, I'm doing okay. And my surgeon 2 days ago said, you don't need PT, you're doing great. Keep doing what you're doing. Not that I advocate going against what your PT or MT or anybody says, right? But you also have to follow your heart and what you're feeling. Did I do too much too soon? Apparently not, because he said I'm doing like outstanding. So yeah, there you go.
And not listening to your patient is a huge knock against the PT that you saw.
Yeah.
You as a patient and a clinician now are advocating for yourself as a patient
Yeah.
in your knowledge. And like, we have patients that have access to, Dr. Google these days.
Yep.
And they can come in and they can advocate for themselves and ask
Yep.
all of the right questions.
Yeah.
And yeah, it's just.
And sure, Dr. Google takes them down the wrong tunnel, and they end up with all kind of wrong information that we sometimes have to unpack some of that. But my PT did not listen to me, right? I went there knowing some of that already. I guess I was already sort of prejudging the whole session. But I also wanted a perspective. I want some benchmarks. I wanted just sort of give me some steps of what you see. And she was kind of unable to do that. And maybe I'm just a jerk to work with, when it comes to that. But, I got what I needed from my doctor. And I know that if I went back to PT when my next visit was scheduled next week, I'd start on, basic clothespin stuff when I'm already doing this work that you and I do for a living. I'm ready to put some new windows in my house next weekend, and et cetera, et cetera. So life is pretty good exercise if we live it,
Absolutely.
Yeah.
Absolutely. Anything neurological that's happening that you've noticed?
I've got, there's some surface, paresthesia a little bit, but that's always to be expected. And, over time, it tends to narrow in its size and nothing at all.
Okay.
Yeah.
Knowing what you know, I guess this is sort of what we've already talked about. Knowing what you know now, applying manual therapy with sort of a neurocentric BPS, pain science, narrative perspective, what guidance, advice would you give yourself, your younger self, for any less experienced therapists?
You mean for this or in general? Because in general,
in general, we've sort of been talking about that already.
Yeah. In general, that's what I talk about online all the time. That gets me in trouble with MFR people because I'm not paying homage to the gods. Well, you know what? It's what it's like in the United States when it comes to MFR. It really is about guru and godlike relationships. And it's just, learn a lot from a lot of different people and don't take any of it as truth, as fact. It's opinion.
I get a lot of pushback from osteopaths about LAST also, because how I teach it is basically how you teach MFR. It's with this perspective and not the old godlike perspective.
Yeah. And then the question about pertaining to this itself. No, I don't. Thus far, my manual therapy skills have been minimally helpful for this, right? A lot of it is just allowing healing to occur and allowing myself just to move back into activity with this and this working, okay? Beyond a little bit of that, I was toying with a little bit of hand flattening, and it's like, you know what? You're probably doing yourself a disservice by even thinking about that. If it's going to open up less of that cupping, let it happen on its own, because I'm pretty active.
Yeah.
So.
Yeah, that's one of the things I get across in the courses and with the patients is that, we've got baby steps. We have to empower our patients in order to take actions to advocate for themselves and improve their quality of life on their own. Yeah. We shouldn't be somebody that they feel that they need to continually see in order to get fixed. So if I can create a plan for them to do, regular ADLs, like putting plates back into a cupboard, just some of the simple basic things you learned at school that you think, oh, this is crap. What am I ever going to use this for?
Yep.
Well, now you can use it.
Yeah.
Baby steps and then testing, right? Okay, well, I'm going to do a little bit of this. I'm going to do a little bit of work. Okay, well, it's kind of pissed off and cranky the next day. Okay, well, that's a benchmark.
Yep.
That's a test.
Yep.
Now I know that I'm going to back it off a little bit, and then at some point in the future, I'll be able to do more.
Yeah.
So,
And it's ironic you said about the plate, because that was one of the other benchmarks that I saw deteriorating, was reaching up and just a dinner plate. Near the end, before I got the surgery, I needed to use the other hand to do it, and that's also my gauge, my benchmark for my own rehabilitation is now, I can put that plate up in there and I don't feel like I'm going to drop it. So I think ADLs are wonderful benchmarks. And I love my patients to establish those firm benchmarks. So they say, okay, that's what I have difficulty. Will that change? And it's so much easier, or it's so much more functional and meaningful than how many degrees of range of motion. Can you get it up there? Can you do this? Can you, whatever that is. I love ADL benchmarks.
What was his hand rehab, joint mobility post-surgery? We basically talked about that. There was some question about specific modalities like MET, distraction mobilization. We've pretty much talked about that. Sort of a general question was, if a therapist is not able to use their hands, what other avenues of careers or streams of income in the same field could you create? I think that basically goes for all of us with any kind of condition that we've got, as far as what other avenues or careers or streams of income, there's always education. You can always go back and teach at a college level.
Yeah.
You can always mentor.
Yeah, there's also a huge amount. Okay, so I don't know exactly what you do specifically, but I know that what I do in the traditional MFR way, it's like the people who told me I have to do it like that are the people who taught it to me, not my patients. And I've learned over the years that I can break a lot of the rules that I was taught in MFR training. And the patients are still saying, oh my God, that feels great, right? So who are we going to listen to? The person who said you always have to do it like this, or the patient who said, when you just did it with one hand, that felt even more helpful, right? So that allowed me to free my brain up from the rules of MFR or any other modality, right? And I know a lot of people who are having trouble with carpal tunnel, it's like, well, it's the recommendation for body mechanics, adjustable table, or modifying your technique. And, can you create a patient load that appreciates lighter work so you're not beating the crap out of yourself and putting yourself as risk? I think that there's a distinction between the traditional PT and the traditional massage therapist, where it's the basic, okay, are you in the service or the healthcare industry? Because the healthcare industry, the patient seldom dictates the intervention. In the service industry, the patient dictates the intervention. And if you're going to be a service provider, then you're going to provide that dictation, meaning you're not pushing hard enough. So you push harder. And I was exhausted after that session. And I want to say, well, why the F did you push so hard? Well, because they needed that.
Needed it.
Like, okay, find a different patient. Find another patient who doesn't need that or is willing. I believe in negotiation. I have my very firm boundaries, but I believe in negotiation. Can we both come to a level of pressure or whatever we're doing, right? Where you feel like I'm being potentially helpful, but I'm feeling like, okay, I'm not going to hurt this person or hurt myself. And I think the art of negotiation is lost on a lot of massage students and then clinicians, because it's basically, you have to do this service for them and they're the one who tells you almost what to do, or you own all the power. No, here's what's best for you and I'm going to do this to you. So isn't there someplace in the middle we could meet with all of this?
Absolutely. That's one of the things I talk about in my class, is that, the body's not a car. We don't fix anything. We are regulated health professions. I try to get people to get beyond their perspective of trying to find things to fix, and that we create change if we facilitate growth. That's the biggest thing. It's just and give hope and opportunity to someone. I find myself being more of a coach these days than a therapist. Everybody has a destination that they'd like to get to, and typically that destination is, I want to get pre-injured. I want to get to a pre-injured status. Okay, well, that might not be a realistic destination, but maybe we can start you on the journey and let's see how far we can go.
Yeah, I think you're, from our dealings, I think you're a person with a lot of grace, probably more grace than I have. The reason I'm saying this is I get in frequent arguments on social media. I let myself get drawn in, and it happened a couple of weeks ago on LinkedIn with a doctor. When you went to his website, it never said what kind of doctor he was, insisting that exercise can never fix a problem because we have to fix the tissues before exercise works. And it's like, how small-minded is that? That number one, we think we can fix tissues. And number two, that exercise or movement-based interventions can never work if the tissue isn't fixed first. And I had enough grace to, after a couple of slugs back and forth, I kind of left the conversation, and it was from, I think it was one from Eric Dalton's posts on LinkedIn, and Eric was probably embarrassed that I was like duking it out with this doctor on his thread. But it's like that whole mindset of where did we find that? Where did we get that we are tissue mechanics fixing what's wrong with it, right? I love the some of our mutual friends on social media, we can't work with a person's tissues. We can only work with a person, right? Despite what you think that you can access a muscle, it's not without a nervous system and perceptions and fears and all kind of other factors involved. You cannot work a tissue in isolation. But yet people are still coming out of school or coming out of modality training, feeling like they've got the secret power to access that specific tissue. And I think that's sad.
Absolutely.
I think people like you and I are trying to unlearn that in people one at a time when they're coming out by the hundreds with that already in place, whether it's from school or from all these harmful modality trainings.
Absolutely. And you know what I've just picked up on? I don't think that it's your left wrist, right?
Mm-hmm.
I don't think that your left wrist is from, the type of work that you've done or the career that you've chosen. I don't think it's from that at all. I think that you're just a southpaw and that you've been hitting all of these guys on social media with it finally has had enough impact.
It might have been because I am right-handed. I played golf right-handed, but as a youth, I played hockey left-handed, right? And now, how weird is that, right? I never, people always say, oh, you must have needed that because of what you do for a living. And the wise ass in me says, yeah, but I do this for a living too. And this one's fine, right?
Yeah.
It's like, I love when we start looking at our own stories and our patient stories of why something happened. And I realize it's just a story for the most part. Sure, if you get your foot run over by a car, that's a damn good story, and it's probably a good part of it, right? But with stuff like this, do we ever really know? I don't think we do.
No. So this has been awesome. Thank you so much for doing this for me. I greatly appreciate it. And if you can, on social media, keep us apprised of how your recovery is going. And it's been awesome speaking with you, man. It was great. And nice. Also, there was also one question. There was a request for you to come up to teach in BC. So
I am, you know what? I'm ready, willing, and able as soon as the damn border opens up. I've got a class in Montreal that I've been holding off on rescheduling, and I'm just waiting and waiting and waiting. So I'd love to get back up there. It's been a long time since I've been there. So love to do that.
Nice. All right, man. Thanks so much for doing this, and we will talk to you soon.
Take care. Bye.
Goodbye.